Morning, everyone. This is Siddharth Damber from Chicago Arthritis and Regenerative Medicine. Welcome to today's webinar, where I will be talking about regenerative medicine treatments for lower back pain. I have roughly about 30 minutes of material to talk about. As you have questions, please input them into the chat or Q&A section, and I will answer them as we go along. Most of the frequently asked questions should be covered in this talk as well. However, if you have specific questions, I'll touch on those as well. And while today's talk is a little bit more tailored on regenerative medicine for the lower back, if you've got questions about other areas of treatment as well, I can certainly talk about that as well. Great. So what you can expect from this talk, we'll talk about what are the best available non-surgical regenerative medicine treatments for your lower back pain. And that includes whether you've got arthritis in the lower back, an injury in the lower back, sciatica, or degenerative disc disease. What is allowed in the field of regenerative medicine, and the key things your physician must know to really show that they're an expert in regenerative medicine so that you can choose the right physician to help you out. And again, after this webinar, if you have any questions, you can always connect with us at our website, chicagoarthritis.com. And actually, lastly, because I see there's other people who are just starting to join in as well. After our webinar today, this is being recorded. If you'd like to see this again, or if you missed the beginning part, you can jump back on, or you can watch it again in replay. So the big question is, what would you do if your lower back pain was controlled? How would your life improve? What exercises would you restart? And what activities with family and friends would you participate in? So briefly, who am I? So again, name is Siddharth Damber, physician at Chicago Arthritis and Regenerative Medicine, specialist in rheumatology, specialist in image-guided musculoskeletal injections, in practice since 2008. Involved in regenerative medicine since 2008 and within the Regenerat Network, which is the largest network of physicians who are involved in regenerative medicine, sharing protocols and expert guidance since 2012. So the traditional problems, or the problems with traditional care when it comes to lower back, are a number of things. The traditional way is, here's some pain medication, here's some ice, rest up. You're not really helping the problem, you're masking the pain, there's no attempt to fix the problem. And in a lot of cases, you're really just waiting for eventual surgery. The equivalent of that in, let's say, something like diabetes or high blood pressure would be like saying, let's not treat this, let's just wait for you to have your first heart attack or stroke, and then let's do something about it. That's a terrible way to treat people. And I think for lower back and in general musculoskeletal conditions, we can do better. Other problems with traditional pain medications, the anti-inflammatory meds, they've got a lot of side effects. Chronic opioid use, we know in this country, we've been just devastated by prescription drug abuse, namely narcotic abuse, and that's a problem with chronic pain medications. Traditional injections that are used by pain clinics include steroid injections, which have side effects. Too many of them can damage tissue, increase the risk of infection, diabetes, osteoporosis, weakens tissue as well. The typical nerve blocks and radiofrequency ablations that they use can give pain relief, but you are essentially burning the nerve, you're damaging the nerve, and that leads to muscle weakness. And if a key aspect of your musculoskeletal health is stability and strength, then anything that weakens that is bad for your overall musculoskeletal health. Surgery, in some cases, surgery can be helpful, namely if you've got bad neuropathic symptoms like weakness in a leg from a pinched nerve. But when it comes to actually just treating pain, whether it's pain down the leg or pain over the back, surgery is not quite as helpful as people think it is. For starters, there's a lot of residual issues that happen from lower back issues, and I'll talk about that in a moment. But these surgeries are higher risk in terms of bleeding, infection, tissue damage, not to mention anesthesia risk. Many routine surgeries, including a lot of routine lower back surgeries, are proven not to be effective long-term. Lumbar fusion can help with neuropathic symptoms, like I mentioned, weakness in the leg, not as good at helping pain. And if you fuse one segment, you can then get the next segment problematic as well, which can then lead to more recurrence of pain as well. The disc surgeries, it's an interesting idea, but the problem is that it risks your chance of instability long-term as you remove tissue, which leads to more lower back issues. Spinal cord stimulators can help with pain. But again, you're putting permanent hardware into and around the spine, which increases risk of infection as well. So if you can find treatment options that are lower risk, you're better off trying to avoid that. Lumbar fusion is one of the most common surgeries done in this country. Its purpose is really meant to fuse the segment above and below where you may have your problem. The problem is that you can then develop arthritis above and below that segment because that same amount of force going through the spine, it's still there. It's just now being displaced above that segment that's infused. So that's number one. And really the idea is that one fusion then leads to the next fusion, then to the next fusion. So next thing you know, you're just filled with hardware. Fusion surgery has not been proven to be better than PT alone for lumbar degenerative disc disease or spinal stenosis. And lumbar fusion, I mean, if you've got chronic pain and disability can persist post-lumbar fusion. And of course, there's also the issue with chronic opioid dependence. And so there may be a role in a small subset of patients who get this kind of surgery, but it's overused in too many people. And that's the big problem. So in searching for better options, we want options that are lower risk, less side effects, improve the actual cause of the problem, and give you a chance for better long-term improvement. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. By the way, I do see some of the questions that are coming in already. They're about other areas. I'll talk about those in a bit. So what is regenerative medicine? It's essentially using your body's own cells to treat musculoskeletal issues. So the normal healing process takes something as small as, let's say, a paper cut to your finger. What you have is platelets that enter that area. They release growth factors, which then stimulate your local mesenchymal stem cells. And then through inflammation and then a slow progressive remodeling process, you then get cellular tissue repair. That's a great form of healing, but in tissues with poor blood flow, they tend not to heal very well if they've been significantly injured or chronically injured. And that can include tendons, cartilage, ligaments, discs, labrum, menisci. So regenerative medicine is a process of taking those same cells, either your own platelets or bone marrow cells, and then under very highly coordinated image guidance, injecting those into the tissue that's been damaged to then help get a similar sort of tissue repair process. So why regenerative medicine? It gives better pain reduction longer term than steroid injections do. By improving stability, it can improve your function. It treats the source of your problem, which is almost always instability and or inflammation, lower risk and safer than surgery, limited downtime post-treatment, limited time off of work, limited disruption of your regular routine, limited use of requiring crutches and mobility tools and things like that are required after bigger open surgeries, effective for most musculoskeletal conditions. And for those of us involved in this, we really feel generally strongly that eventually 80% of traditional orthopedic surgery, including spine surgery, should be managed by these kind of treatments. In the same way that previously traditional open heart surgery, 95% of that is now handled via either needle-based procedures like stents or via medication. So we talked about how regenerative medicine works. Essentially, we're optimizing damaged cellular tissue. In addition, by treating some of the soft tissue supportive elements around a damaged area, you can actually strengthen the tissues and improve that overall functional unit more than you can just by treating that one structure that's been damaged. That improved stability then leads to better pain relief long-term and better function. We mentioned reducing chronic inflammation longer than steroid injections. And again, we can improve the irritation around nerves and also improve some of the weakness and atrophy that you get in muscles as well, all which improve stability of the spine and then also improve pain long-term. Some other very basic FAQ questions. Is this legal? Yes, there are very strict guidelines from the FDA. The main guidelines are you have to use your own living cells, not somebody else's living cells. Number two, the cells cannot be overly manipulated. There's specific things that you can and cannot do to make this legally appropriate. And lastly, needs to be injected into damaged orthopedic tissue. We're not talking about treating, let's say, traumatic brain disease, heart failure, kidney failure. We're talking about treating issues like a pinched nerve in the back or arthritis in the facet joints in the back or injuries of the lower back. Common question I get is, if I'm older, shouldn't I use somebody else's cells? Simple answer is no. For the vast majority of orthopedic conditions, there's good evidence that using your own living cells is effective. And there are additional risks when you're using somebody else's cells. There's very little evidence that using other people's cells is beneficial as compared to 20 plus years of evidence of using your own cells for your own musculoskeletal conditions. And in fact, using somebody else's living cells in this country is really only limited for childhood leukemias and is otherwise not allowed. So is there an age limit? Simple answer is no. For the vast majority of conditions, they do fine with using your own cells. And that includes for the lower back. The one exception to that are the hip, where if your age is over 60 and you've got advanced arthritis, hip issues can be harder and generally should go to surgery. What sort of doctor does these treatments? My recommendation is you want to look for the following. Number one, someone who's focused on musculoskeletal conditions day in, day out. They shouldn't be treating somebody's blood pressure on one side, treating somebody's erectile dysfunction in another room, treating somebody's age management issues, and then jumping in to treat your lower back. They should be focused on musculoskeletal conditions. That's how you develop deep expertise. Number two, they should be focused on non-surgical treatments for orthopedic conditions. My surgical colleagues are very good at surgery. They don't have the same training for using ultrasound and X-ray guidance for treating musculoskeletal issues. They may dabble in these kind of treatments, but they don't have enough expertise in that. And you cannot do these kind of treatments appropriately without that kind of image guidance. And then lastly, they should be a proper regenerative medicine expert, which I'll talk about. But I see a lot of pain clinics where they may have the technical skills to do these kind of injections and treatments, but they don't really know how to use these properly. And what happens is they'll offer nerve blocks and steroid injections in some patients, and other patients with the same conditions, they'll offer these kind of the regenerative treatments, and they're dabbling in it. They're not a true expert. And you really, again, in something like medicine, you only get deep expertise if you're really doing this intensely every single day. So can these treatments help if I've already had surgery? Simple answer is for the most part, yes. The only times when it's no is if a joint's already been replaced. But pretty frequently, we've seen people who may have had a prior surgery, either microdiscectomy surgery for the lower back, sometimes even fusion surgery, and those patients can still improve significantly. My general rules for people who are considering orthopedic surgery is number one, try to keep your own anatomy, avoid surgeries that cut out tissue. Always consider a regenerative medicine treatment option if you have been recommended surgery. So we'll talk about some key regenerative medicine concepts, and we'll talk about how your physician should be aware of these. So stability is a very key one, and there's this concept in regenerative medicine called biotensegrity. Tensegrity is this concept from architecture, which means that if you take individual units, on their own, they're very weak, but when you put them in close approximation to each other and with compression, you get dramatic more strength and stability. You see that in architecture everywhere, whether it's high rises, bridges. So that same concept exists in the biologic and medical sphere, and that's called biotensegrity. And so prolotherapy is the idea of taking your own cells and injecting them into the soft tissue supportive structures to strengthen and stabilize those tissues. And the key there is you want to treat every layer that's pathologic in an area that's been injured or chronically damaged or painful. That'll lead to progressive strengthening over time. It'll give longer lasting results over time as well. So this is a nice set of pictures on the right side, and lumbar stability is key. The pictures on the right, you see normal, mild, moderate, and severe. What they're showing is the multifida muscles. The main difference between these pictures is how much more white you see in the muscle area. It's key because that is a sign of atrophy. It's a sign of weakness of the muscle. That weakness develops over time, and it's something that is due to damage to the nerves going to those muscles coming from the spine. We can treat those issues, and it's a key area of treating stability, which will then give better pain relief long-term. So by treating all these layers, let's say, for example, in a degenerative disc disease patient, you're treating the facet joints, the epidural space, ligaments, and muscles. Every layer. That's what gives people a better result long-term. And even in sciatica, where you've got a pinched nerve, you want to treat not only the nerve that's been pinched, you want to treat the other tissues that are there to provide more support and stability as well. If you do that, people get dramatically better results. So this is an example of a 45-year-old man with chronic lower back pain from spinal stenosis. In his case, we did PRP treatment. The picture on the right is injecting his own platelets into the epidural space at the L4 level. We also, in his case, ended up treating his facet joints and his ligaments. And it's an example of what you can get. His MRI on the left is an MRI that's read as he has some degree of spinal stenosis. You can see the disc pooching out right there. And this is the spinal canal. And so it's really impeding the ability of the nerve roots to kind of get out cleanly. And this is him after treatment, where now you see a significant reduction in that pressure against the spine. So how do we do that? It's not just by injecting into the epidural space, it's also by injecting all the soft tissue structures around there as well. And what that does is it gives better stability to the spine, which then takes pressure off the nerve as well. So in his case, he's been able to get back to significant activity, better quality of life. He's doing very well. So orthobiologics are the cells that we're injecting. They're essentially the cells and tissues that are injected into the damaged tissue. This uses a normal healing cascade. Again, use your own cells, not somebody else's. Platelets are the first-line treatment in regenerative medicine. So again, after an injury, platelets are the first cells that are involved in terms of recruitment, stimulating your own stem cells. The picture on the right, you'll see there's different types of platelets that we can make. The picture on the right, you see an amber-colored or yellow-colored platelet-rich plasma. That's what we want. That's a high concentration of your own platelets without the red blood cells. Then there's a picture on the right. That's platelet-rich plasma with some red blood cells. That's more inflammatory. We prefer not to use that. We make other types of platelets as platelet preparations as well, including platelet lysate. That's where we only take the growth factors from the platelets and re-inject that. Key to understand that we use different types of platelets depending on what's the tissue that we want to treat. The platelets that we want to use for joints are different than what we want for tendons, are different than from ligaments, and are different than from the nerve. If your physician has a one-size-fits-all process, which frankly most physicians do, you're not getting the ideal treatment. And you want a physician who understands the nuance and can get you the right treatment for your full set of issues. SI joints, sacroiliac joints are another really common area that can drive lower back pain. It's a 7-year-old woman with chronic lower back pain and hip pain. This is actually my mother. I've treated her SI joint with platelet-rich plasma. She's had great improvement in pain as well as function, including jogging a 5K race here and there, exercising daily, working full-time. That's really a great result. And the key here is treating not only the joint, treating the ligaments as well, and recognizing that platelet-rich plasma gave her dramatically longer and better pain relief than a steroid injection has in the past for her. Stem cells are the next type of orthobiologic that we use. It's the main cell line that drives tissue repair after an injury. Using cells from you is important, not somebody else. In the United States, only bone marrow-derived stem cells are what's legally used Fat stem cells are used in other parts of the world. They're not legal in the US. We will at times use fat or adipose for structural support, but not really as a stem cell treatment. You probably don't hear too much about this any longer, but in the past, you may have heard about amniotic or umbilical cord cells. There's no living cells in those products after they've been processed. So a lot of the companies that used to be selling these to physician offices have now been put out of business because the FDA has basically clamped down on them. If your physician is using those rather than your own bone marrow stem cells or your own platelets, they may not be aware that there's no living cells in the umbilical cord and amniotic fluid products that they're using. Don't hear too much about IV stem cells nowadays, but that's been used in other parts of the world as well. No proven benefit for orthopedic conditions. Again, use the treatments that have been proven to work. Stem cell treatment outcomes. So we can improve pain and function even in advanced cases. And it's not because we are reversing time. We're not able to take a damaged joint that's been damaged for decades and turn it back to what it was decades ago. We can't do that. We can, however, improve stability by treating the ligaments and tendons. We can, however, improve inflammation longer term by treating the joint and even the bone. And we can get those cells in that area to start functioning better, which will then give pain relief, functional improvement, which will then let you do more exercise, which will then help with strength and stability and ideal body weight, which on its own will help as well. So can we improve images? If you have advanced arthritis, we can't improve what an X-ray looks like. However, if you've got swelling in the bone, someone had asked about bone-on-bone arthritis in the ankle. And so we can actually help with something like that as well. You can actually get the swelling in the bone to dramatically improve or even resolve. We can help with smaller tendon and ligament tears as well. And we can also help with a condition called avascular necrosis. So the vast majority of musculoskeletal conditions that present day in, day out to a physician's office are things that are still very treatable with regenerative medicine. It's an example of a 71-year-old man who had chronic lower back pain. He's had 2 laminectomy surgeries in the past, still having pain. Pretty classic, right? Someone who's had prior lower back surgery and still having pain. Treated the full area in terms of ligaments, facet joints, muscles, and epidural space with his own platelets originally. Get about a 30% pain relief. We then escalated to using his own bone marrow stem cells. He's now at a 75% improvement. Great example showing how even if you've had surgery, you can still respond to treatment, how sometimes multiple treatments may be required, and how escalating from platelets to bone marrow stronger, how that gave a better result. The picture on the right, by the way, is a needle injecting into a facet joint. In his case, he had arthritic facet joints, and that's what we injected his own bone marrow stem cells into, and he's done really well. Before I move on, let me just answer a couple of questions that I see in the Q&A. So somebody asked about bone-on-bone arthritis in the ankle. As I mentioned, yes, we can actually help with that by improving stability as well as improving inflammation long-term. Somebody's asking about hip pain and mobility. Depends on the status of where the hip is. If you are over the age of 60, and if you've got advanced hip arthritis and you have very limited range of motion, that's a hard one. I would generally recommend hip replacement. On the other hand, if that's not the case, you may still respond adequately to treatment. Somebody else asking about arthritis in the right hand. I have a good amount of experience treating hands because I see a lot of hand patients as a rheumatologist. And in my experience, these joints, which can be so small, surprisingly can actually respond to treatment. And yeah, I would say that is still very much a treatable condition. Okay, Mr. Hafner, thank you for the message. Absolutely, we'll be sending out a link to folks after we're done to replay, to watch us again. Okay, somebody else asking about knees, delaying or healing arthritis after knee meniscectomy. Absolutely. Probably one of the most common, the most common issue that we see are knee issues, and the second most common are lower backs. But the number of people who've had knee meniscectomy surgery in the past and then come to us, absolutely, that's kind of bread and butter. We see that all the time. Treating that completely and fully, you can still get significant pain relief and improvement and prevent the need for knee replacement for some time. Okay, somebody asked about blood thinners. It's tricky. It depends on what treatment, depends on what area you're treating. If you're prone to blood clots, we'd normally want to have coordinate with your prescribing doctor about, can you hold your blood thinner for the day of your procedure? Also depends on which procedure. Let's say you're getting just platelet-rich plasma. It may just be a matter of holding it for the day of procedure. Not a big deal. If it's bone marrow, because if bone marrow aspiration is involved, we may ask if you can hold your blood thinner for a few days longer than that. So if your treating physician feels comfortable with you holding it short term, then it should be fine to actually have treatment. So other questions that I frequently get, can we treat bone-on-bone arthritis? I just answered that with someone who's asking about the ankle issue. For sure, you can still get significant improvement in pain. Again, understand arthritis is not just a picture on an X-ray. It's a biologic condition treatable with these kind of treatments. Again, there are caveats to that. Bone marrow stem cells may be required if PRP is not adequate. I gave a case example of that. Even in advanced arthritis, we can improve pain and function. Imaging improvement can be harder. Okay, somebody raised their hand in chat. I'm not exactly sure how to help somebody out with their raised hand. Maybe that was done accidentally. But if you have a question, please shoot it to me in chat or Q&A. And I'll certainly answer any questions you may have. Disc disease, another common one that we see. Degenerative disc disease, again, key is to treat all the pain generators. You don't need to inject into a disc. There's a little bit higher risk of injecting into a disc. But if you treat all the other pain generators, that means the epidural space, ligaments, facet joints, muscles, you can still get a great degree of pain relief. I'm showing that picture again on the right, the MRI picture of the individual with spinal stenosis, and just what a great response he had after being treated with PRP. Discogenic pain, meaning pain that's really coming from the disc, whether it's a herniated disc or a torn disc. If you're young, if there's really not any other pathology in the back, then an intradiscal injection can be helpful. But if there's any other issues outside the disc, you want to make sure to treat that as well. Image guidance, very key. I have colleagues who swear that just by palpating the patient, they can know exactly where to inject. I think that's nonsense. As long as I've got X-ray and ultrasound availability, I'll always use that to guide my injections. In particular, when you're injecting the spine, there's a lot of delicate issues there. You don't want to hit something accidentally. That should not be hit. And number two, when you're injecting cells, this is different than injecting steroids. When you're injecting cells, you need to be absolutely precise. You have to be at the sub 1 millimeter level to get the right kind of result and the right kind of injection. These are images that I showed before, but image on the left is of a SI joint injection. Image in the middle is of a transforaminal epidural injection. Image on the right is of a facet joint injection. Have to do all these treatments under image guidance. If not, then you may not be getting the right kind of outcome. So how do you know if your physician is a regenerative medicine expert? A couple of key things I'd recommend. Number one, focus on orthopedic and musculoskeletal tissues only. Only focus on that. Number two, focus on non-surgical treatments. If they do 99% of their time in surgery and 1% of the time they're trying to do these kind of treatments, they're not going to be an expert in regenerative medicine. They should only offer safe and effective treatments, meaning avoid steroid injections, try to avoid anti-inflammatory drugs, try to avoid burning nerves, which is a common procedure done by pain clinics. If they're doing that 90% of the time and 5 to 10% of the time they're doing regenerative medicine, again, they're just dabbling. They're not full-on experts. When you get evaluated, they should be able to give you a candidacy rating. That candidacy rating should not be based on just their gestalt sense. It should be based on what's the proven evidence Thankfully, in the Regenerative Network, we have that. And we can tell you pretty clearly, are you a good, fair, or poor candidate? They should be actively collecting and publishing data. That's certainly something that we do in the Regenerative Network. Should be using image guidance for all treatments. They should understand how to treat instability, not just treating the one structure. So the classic example that I see is someone who's got knee arthritis and they had PRP treatment, and they'll tell me that, well, they injected it into the joint and that's it. They didn't treat any of the ligaments, any of the tendons, anything else. And I know that they didn't get a proper treatment, and that's probably why they didn't really respond very well. They should know the exact concentration of platelets and stem cell count they're injecting. You'd be surprised how few physicians know that. They're not measuring that. They're not aware of that. Hard to really say, are you injecting the right stuff if you don't know what you're injecting? And then they should really understand the different types of orthobiologic products. They should understand when to use high concentration platelets versus low concentration platelets, when to use platelet lysate, which is just the growth factors from the platelets, versus platelet-rich plasma, when to use bone marrow, when to use a high concentration of bone marrow versus regular bone marrow, when to inject different types of cells from the different types of tissues, and even when do you use adipose if you're using that as a adjunctive treatment as well. Without those kind of details, you're not working with a real expert, unfortunately. So regenerative medicine treatments offer safe and effective solutions for your pain. Okay, great. Let me just answer a few more questions here. So somebody asking, they've had 3 epidural steroid injections for the lumbar spine. Would those injections limit the potential success of prolotherapy? So prolotherapy is, again, a type of regenerative medicine treatment. I think simple answer is it'd be better if you hadn't had the epidural injections, steroid injections, but you'll still be fine with treatment. You want to give it at least minimum a month since your steroid injection treatment, but you'd probably still do well. Pretty common that we see people that have had prior treatments like steroid injections, like surgery, and they still do well with treatment. So you are okay to pursue that. Okay, somebody else asking about their hip again. Both hips being very limited. Based on how you're describing your issue, the right way to really do it is to get evaluated. Limitation in the hips, is that because of pain? Is it because of arthritis? Is it because of a soft tissue issue? I think you need a little bit more, you need a bit more evaluation before anyone could really legitimately tell you whether you should consider a regen med treatment or you should consider surgery. Okay, somebody else asking about torn shoulders relief. How about torn shoulders relief with surgery? I'm not sure if they mean they've had a torn rotator cuff, they've had surgery, and they're still having pain. Absolutely, as long as the tissue is amenable to treatment, and we can tell that based on imaging, then that's certainly something that can still be treated. Somebody else asking about muscle weakness in MS. You have to understand, MS is a central nervous system condition. I am unaware of any evidence that these kind of treatments can help in the setting of MS. On the other hand, if you have, let's say, pain because a joint got arthritic because of weakness in the leg, that could still benefit from treatment. If you have a pinched nerve in the back or in the peripheral joint, that can still get benefit to treatment as well. But MS specifically, I'm not aware of any evidence to say that's appropriate for these kind of treatments currently. Somebody asked about bruised meniscus require this therapy. My suggestion is if you've had an injury and if you've pursued some conservative treatments, to me that means temporary rest or reducing activity, doing some physical therapy to get back into activity, taking some supplements. If you've done those things and you're still not back to normal, then consider this kind of treatment. Absolutely. Somebody else asked about foot drop. Depends on why you have the foot drop. If you have a foot drop because of a pinched nerve, yes, that could still benefit. If you have a foot drop because, let's say you've had chronic diabetes for decades, then I would not necessarily expect these kind of treatments to help. May alleviate some of the pain, but probably wouldn't help with the foot drop. But again, if your foot drop is due to pinched nerve, absolutely, these kind of treatments can still be used. Okay, great. So other questions I commonly get, is this too good to be true? So I have colleagues that say that what I used to see amongst some of my colleagues back in 2008, when I first got involved in this, was they would tell patients they didn't think these treatments worked. They didn't know the evidence, but they just said they didn't think it could work. Now, 14 years later, I hear those same colleagues telling their patients, it might work, it might not, but it's worth a shot. And in both cases, they're still wrong in the sense that they'll tell patients that this is a new field, but that's not accurate. It's rapidly developing, but there's evidence that goes back to the mid-90s. And so there's more than enough evidence to suggest what's the right way to do things and not the right way to do things. And I think for my colleagues that tell patients they don't know if it's going to help, but they could try it, I don't think that's the right way to give a recommendation to a patient. If you know it's going to help, you give the recommendation that you should try treatment. If you don't know if it's going to help, I don't know if I'd necessarily recommend treatment. But a lot of times the things that they're not sure if it's going to help, turn out there's actually evidence it's going to help. And so it's more a area of just being unaware, being a bit ignorant as to the evidence of its effectiveness. So there's certainly right and wrong ways to do treatment. Your expectations should always be grounded in reality and evidence-based medicine. If you're working with a doctor who puts up an X-ray and shows, hey, look, here was his knee before treatment, and now here's his after knee, and now look at the dramatic improvement. And it turns out they've just been checking a slightly different view, and they're kind of playing games with it. I would avoid those kind of doctors. Be grounded in reality and evidence-based medicine, and it's pretty good evidence right now. How long do results last? In the Regenerat network, there's data that goes over 10 years. Philippe Hernigue in France, a French surgeon who's been doing this for the last 25 years. He's got long-term data as well. What I tell people is for a chronic condition, expect that repeat treatments at some point will be needed a few years after the initial treatment to keep your result going. Best way to maintain results are improve your biomechanics, take the appropriate supplements that help for joint issues, and repeat treatment can be additive to the initial treatment if needed. Costs, these are not routinely covered by insurance. The exception being the Regenerat corporate plan. If your company is self-insured and you're looking to see if you can get these kind of treatments covered by your insurance plan, go to regeneratscorporate.com. They can walk you through how to add this to your plan. There's roughly 500 plus companies in the country right now, that kind of medium-sized companies to large-sized companies. They currently offer the Regenerat benefits to their insurance plan. But for everybody else, the cost estimates in the US are roughly PRP, $2,500, and bone marrow stem cells, $8,500. The keys to determine value I would recommend are, number one, is your physician and the clinic, are they actually regenerative medicine experts, or are they dabbling and are they kind of amateurs? Are you receiving a real stem cell treatment or something that's been miscategorized, like an amniotic or umbilical cord treatment? And keep in mind that these are in-office procedures. You don't need to go through a hospital, inpatient setting, surgery center setting, where you've got now dramatically more expensive facility fees. So a little bit more about how we do things here at Chicago Arthritis and Regenerative Medicine. Focus on non-surgical treatments for your musculoskeletal issues. Always starting a evaluation, big picture, give any inflammation, instability, asymmetry, or neuromuscular issues. Correct those with low-risk interventions if possible. If not working, and if you meet the right criteria, then escalating to regenerative medicine treatment using the best quality products from your own body, a plan that is specifically tailored for your condition, not a one-size-fits-all process, and delivering cells using the highest level of image guidance to make sure we're hitting the right tissue and giving you the best possible chance of a great result. So how do you get evaluated if interested? You can either go to the website, chicagoarthritis.com. In the chat section, you can either click on the website link. We've also got our phone number as well as email address if you'd like to schedule an evaluation with us. Or frankly, if you have any other questions or anything else you'd like to discuss about about what we talked about today? Okay, great. Somebody asking about cervical stenosis. Simple answer is yes, cervical spine stenosis can certainly be treated. Again, need to be evaluated first to see if you're a right candidate. I personally do not treat neck or cervical spine issues. I defer that to a couple of my other colleagues, but certainly can still be treated. It's a tight area, but definitely with the right expertise. And if you're the right candidate, that can still be treated for sure. Wonderful. Well, we're coming to the end of our talk today. If anybody has any remaining questions or issues, please let me know. If not, I will start to wrap up things. Expect to get an email from us with a replay option if you'd like to watch this again. You can forward that to a friend or family member or colleague if you think they may benefit as well. Thank you, everyone, for your time. Someone just came with one last question. Talk a little bit more about PRP and fat. Yeah, I mean, PRP is really that kind of initial regenerative medicine treatment. Works great for a lot of mild to moderate things. We'll use adipose or fat as a structural graft. As an example, let's say you have a rotator cuff injury or a small tear. That's a great case where you could use PRP and fat, or bone marrow stem cells and fat. So fat is generally an adjunctive treatment that I'd recommend using for a lot of the soft tissue issues that you can see. I generally do not use fat as a standalone treatment because I think you do need some of the other cells to get the best kind of response. Thank you very much, Yusuf, for the kind words. And if there's any other questions, please let me know. Otherwise, call it a day. And look forward to connecting again in the future. Look forward to helping out in any way if possible. Thank you very much, everyone. Have a good day and live well. Bye-bye.